Okay, the skill today I'll be demonstrating is nasogastric intubation. So the first thing you're going to do is you're going to check your physician's orders, and you're going to gather your equipment. The equipment that you'll be needing is your gloves, your NG insertion tubing, lubricant, 60 cc syringe, a stethoscope, and a cup full of water. So then you're going to go to your patient and you're going to assess your patient. And how you're going to assess is you're going to look at their nares and you're going to look for the largest nare, and you're going to leave the largest nare open for air to pass through that, and utilizing the smaller nare to pass the tube. You want to ask your patient if they've had a broken nose or a deviated septum. If they have, you may not be able to insert the NG tube. So then what you're going to do is go ahead and grab your tubing. After you've placed your patient in a high Fowler's position, you're going to measure the tubing from the nose to the ear down to the xiphoid process, and then add 2 fingers. That will tell you how far your tube needs to be placed. Go ahead and mark your tubing so you know how far to insert it. Then you want to go ahead and get your gloves on. Your patient, you may want to let your patient know this is a very uncomfortable procedure, that you'll be done quickly. They may gag, they may vomit, so you would want to have the proper PPE on, which would be gloves, gown, and a goggle. Then you're going to take your tubing and you are going to lube it up very generously. Tell your patient to tilt their head back while you start to insert the tubing. You go till you hit the gag reflex, and then once you've hit the gag reflex, you want to give them a second to compose themselves, and then instruct them to dry swallow, or if possible, to have sips of water while passing the tube. Just depends on the order, if your patient is NPO or not. So I give him a second, and then I ask my patient to tuck his chin down to his chest to pass the tubing easier. While he's doing that, and I'm instructing him to dry swallow, I continue passing the tubing down until I get to my mark. Once I've gotten to my mark, the biggest thing here is to make sure that you are in the stomach and not in the lung. So once I've gotten to that point, I'm going to go ahead and start with my 3 checks. And my first check is going to be auscultating, listening to air. So I take my syringe and I get about 20 cc's of air and attach it to the end of the tubing. Place the stethoscope in my ears and over the abdomen. And at this point, I quickly inject the air and listen for the whooshing sound, which is an indicator that I'm in the stomach, not the lung. My second check will be to aspirate, which is to pull back stomach contents. And I'm looking up here at the tubing, and once I visualize the stomach contents, I replace them as to not upset the pH balance of the stomach. Remove the tube and then place in a cup of water. If there's no bubbling, this is a good indicator that I'm in the stomach, not in the lung. If I were in the lung, it would be bubbling. So that is my 3rd check. My 4th check would be to send my patient to x-ray to confirm if it is in the stomach. Once you've gotten the tube down and your patient has gotten better, the doctor may order the tube to be removed. Before removing the tube, you want to make sure that the patient can tolerate their stomach contents. So you're going to clamp off the tubing for approximately 2 hours and wait to see how they're doing. At that point, if they're not nauseating and they have not nauseated and they haven't thrown up, then you can remove the tube. Then you take some sterile water and you basically clean the tubing. When you're done with that, you're going to go ahead and let your patient know what you're doing, that you're taking the tube out, that you'll be slow and steady. So then you simply, slowly and steadily take it out. Once you have the tube completely out, you wrap it